Değerli meslektaşlarım, hepinize selamlar, sevgiler, iyi akşamlar. Profesör Malinger'i çoğunuz tanıyorsunuz, biliyorsunuz. Özellikle CNS, merkezi sinir sistemi malformasyonlarının prenatal tanısında ve yönetiminde çok deneyimli ve tıp literatürüne çok katkısı olan bir meslektaşımız. Çok sayıda yayınıyla, temel yayınıyla bu konuda hakikaten ufuk açtı ve sınırları zorladı. Yani corpus callosumu, posterior fossa'yı, sulcus gyrus anomalilerinin ilk deneyimlerini kendisinden biz dinledik, öğrendik, yayınlarından öğrendik. Özel bir nedenle ülkemizi ziyaret edecekti bu ara ama İstanbul'dan ve kendisi İstanbul'dan sizlere bir sunum yapmayı teklif etti, önerdi. Ancak son anda ortaya çıkan COVID-19 kısıtlamaları nedeniyle gelişini tehir etmek zorunda kaldı ve bugünkü sunumunu İsrail'den yapıyor. Gene aynı gün ve aynı saatte. Bugün bizlere son zamanlarda karşılaştığı bazı zor vakalar ile ilgili deneyimlerini aktaracak. Bu vakaları kendisiyle tartışma imkanı da bulacağız. Oturumu arkadaşlarım Profesör Recep Az, Profesör Ahmet Gül ve ben birlikte yöneteceğiz. İnteraktif sunuma çok açık bir kişilik. O bakımdan sanırım öyle akacak olay. Vakaların sunumlarını takiben sizin sorularını biz kendisine aktarabileceğiz. Böylece akacak, gidecek. Professor Malinger is a leading scientist who has contributed greatly in the field of prenatal diagnosis, especially in the diagnosis and management of CNS malformations. He has many major and basic publications on this area. We learned a lot from him. Today, he will tell us about the experiences with some of the difficult cases who has encountered recently for the last year, for example. Thank you in advance for his presentation. Gustavo, we are listening for you.
Okay, thank you very much. What I am going to do today is to discuss with you some interesting cases we have during the last years, particularly during the last year. And I will start with two cases that it takes us years to understand what we were seeing. Okay, and the fishes here are fishes from the Red Sea that I found them that are quite nice by their colors. So I hope you also enjoy the fishes. Case one, we saw this patient in November 2020, a few months ago, at 15 weeks and 3 days. And the patient was referred to us because of bilateral CPC. And the moment that you see a CPC early, before 17 weeks, 18 weeks, you should suspect that this is not a CPC. And those are the images that we were able to take. And you see these two cystic masses that appear inside the lateral ventricle. And this is the case. And eventually, very fastly, I remember a very old case we have. We saw this patient in 2003 and was referred by Professor Agiron, that he is my mentor because of bilateral CPCs that were seen early in pregnancy. And these are the images. And you can see that they are very similar. And this is another image. I keep it in my files because I was never sure that we reached the correct diagnosis. But you can see that they are very similar. We follow the patient at 21, 22 weeks. It is at 20 weeks and 3 days. And by this time, the cyst was not in the choroid plexus, but was here. And we were able to see in the patient that the cysts were bilateral. There was mild ventriculomegaly at 20 weeks. And also the walls of the lateral ventricle were irregular. The patient decided to go for termination of pregnancy, but we were never sure what we were seeing. We looked in the literature at this time, and we found a disease that is called bilateral striatal necrosis. It's a a disease that has been described by pediatric neurologists in children. And we call, for years, we call this is bilateral striatal necrosis because we didn't have another name for that. During the years, I saw another case, and the third case was in 2018. It was a patient that was seen at 14 weeks and was diagnosed with bilateral choroid plexus cyst. And at 21 weeks, the physician that performed the examination outside the hospital make a diagnosis of suspected agenesis of the corpus callosum with CPCs. And this physician referred the patient for an MRI, and this is the MRI that what we usually do. We do not perform MRI so early in pregnancy, but in this case it was performed, and you see that the corpus callosum is dysgenetic, is present, but it's quite weird, strange. And you see here these two findings that were again also by the MR diagnosed as choroid plexus cysts. And this is the ultrasound that was performed more or less at the same time in 2018. And you see that the corpus callosum is quite thick, dysgenetic. You see exactly the same finding that are seen in the MRI by the ultrasound. And here you have another image. In 2018, we did another look at the literature, and we were able to find by this time, we discover what's called the ganglionic eminence. We always speak about germinal matrix, but we're not used to speak about the ganglionic eminence, but and what is important in first term, and we are going to publish that as a simple letter to the editor, is that those are ganglionic eminence cavitations, and they are not choroid plexus cysts. We published that as a letter because we were willing that people will be able to understand that fastly, and not to wait for to be accepted as a paper. And you see the cavitation of the ganglionic eminence, and you can see also that the lamination of the brain is not completely normal. You can see here the arachnoid space with fluid. You see this echogenic line. These are the meninges. Here you see the cortex, but you see that something that is not common is that the subplate is very echogenic, and you see a very, very clear differentiation between the subplate, the cortex, and the meninges. We look in the literature, and there was a paper published by Andrea Regini from Milano, and the paper was published in 2013, if I am wrong, and they described by MRI 5 cases of exactly the same. They saw different types of cysts, and all of them quite late in pregnancy. And look how similar are these cases with ours. And all these patients have also pathology of the corpus callosum and malformation of cortical development. And they call it bilateral cavitation of the ganglionic eminence, imaging sign of altered brain development. They correctly say that the destruction of the ganglionic eminence, something happened there, and since the ganglionic eminence early in pregnancy, before 20 weeks, surely before 15 weeks, is a place where neurons develop and they migrate in radial shape. If something wrong happens there, all the whole brain, including the cortex and the corpus callosum, will be abnormal. And this is another paper was published one year ago, again from Italy, and they wrote exactly the same, and they describe exactly the same type of anomaly, and I think that they are quite similar what we call PVPCs, but PVPCs occur late in pregnancy. It's rare to see PVPCs during the second trimester. Usually they appear during the third trimester after neurons have migrated. So they do nothing. In these cases, when you see a normal fetus that by 32 or 34 weeks have cysts in the same place, it's nothing because it happens after migration of neurons. If it happens very early, as we show now in our cases at 14, 15 weeks, the prognosis is always very, very bad. I can stop and ask for comments. Have you seen similar cases?
Especially, I don't have any experience about ganglionic eminence cysts. Okay, I don't have. But practically, when I listen your presentation, what do you think if routinely any physicians see any choroid plexus cyst, what kind of behavior do she or he offer in this
This is the
situation?
point. This is exactly the point.
Yes.
If you see something that seems a choroid plexus cyst, usually they are bilateral, very early in pregnancy, before 17 weeks, let's say. This is not a choroid plexus cyst. You should differentiate between the choroid plexus and the ganglionic eminence that is placed anterior to the choroid plexus. Usually the choroid plexus, in most of the cases, there is no choroid plexus there. And the moment that you go to a sagittal or to a coronal plane, you see that there are positioned in a place that will be the future caudate nucleus. But in the fetuses, the caudate nucleus is very small, and the ganglionic eminence is very big.
The cyst is exactly not in the ventricular system, just near to the ventricular system. Exactly. In this case. Yes. Okay. We only misdiagnosis, missee. There is another question from a friend. There are a lot of differences between corpus callosum nomograms. What's the reason? Which nomogram do you prefer? That's the question.
Mine. But you know, actually, it turns over that I'm almost working for 30 years in the development of the corpus callosum, and what I realize, and I am going to send an abstract about this to the ISUO Congress. And my paper will be called 50 Shapes of the Corpus Callosum. I took 50 consecutive images of the corpus callosum at between 22 and 23 weeks of pregnancy, and the differences in normal corpus callosum are huge. If you look at all the tables, also by ultrasound, also by MRI, the 50 percentile, okay, or the mean is more or less the same. The problem is, as with all curves, what happened at two standard deviation. And the range of two standard deviation with the corpus callosum is very big. So actually, I think that today, if the fetus has a normally appearing corpus callosum, the size is less important. And I know that there was a lecture by Sher in Kypros lectures that they was told that not to measure the corpus callosum. And I think that if the corpus callosum looks to you normal, there is nothing else, it's better not to measure, because you are going to make more damage than doing well.
Okay. Another small question. Do you have postmortem examination results about this ganglionic eminence cysts? A question.
No, I don't have, because usually when you make diagnosis so early, we do dilatation and extraction. But look here in the paper by Regini. Yes, there is histology. Okay, and what they found here. Okay, this is the cavitation. Okay, and when they found here, you see in this image, you see my mouse.
Mm-hmm. Yes.
You see the mouse?
Yes.
Okay, what you see here is this is polymicrogyria.
Mm-hmm.
And here you see a very destruct. This is the epithelium of the lateral ventricle that is also abnormal. Is without cells. It is very irregular, and they think that the damage is a damage that goes also through the cortex and also into the lateral ventricles. And this is why I saw the irregularities of the lateral ventricles. Because of the ependyma, it has been destroyed.
Okay, thank you very much.
Sorry, Professor Manninger, I want to ask a question about in this manuscript article, bilateral ganglion eminence cyst defined halted by brain development. So the main etiology is the developmental or gradation anomaly, or is the vascular maybe?
No, I don't think it's some kind of insult, but we don't know exactly what happens there and why these cavitations appear. Probably it's an early insult, but I am not sure. Absolutely not sure.
Because it's bilateral. I mean, it's very strange.
Yes, it's strange. Yes. As I am going to show with the next case, sometimes it will take years to reach a. The answer to that will be probably by exome. If this patient will have some kind of a mutation, and today the genetic conditions and the insults are becoming together because there are some de novo mutations, some mutation that they cause insults. I am going to show you now. Wait a minute.
And the last question, please. What about the prognosis of isolated cases?
I don't think that these are isolated because the moment that you have a damage in the ganglionic eminence so early, all the cases that we have seen were abnormal. They have all ventriculomegaly, abnormal corpus callosum, and also abnormal cortical layers because the neurons don't reach there. If there are no neurons that are migrating, the corpus callosum don't develop or develop wrongly, and also the cortex is wrong, and also you have ventriculomegaly. So all these cases that have been described until now that occur early have a very bad prognosis.
Okay, thank you very much.
Okay.
Go on, please, Manninger.
We move to case 2. And again, it's an historic case. Perhaps you have seen this case in my lecture. It's a case, I perform a routine examination at around 22 weeks, and I found these hypoechogenic lesions. Okay, and at this time, I only was able to describe them. I call them periventricular hypoechogenic hyperechogenicities with echogenic borders. And I follow the patient, and they become cystic, and at some point the cysts were connected with the lateral ventricles. And since it was the only finding, we were not sure what to expect. The pregnancy continued. Sorry, I have another time the same problem. Please excuse me for an instant. Excuse me for an instant. There is a problem, a serious problem here with my computer. I need to go out. Two minutes.
Okay.
This girl was born, and this is the postnatal MRI by the age of 2.5, 3 years. And you see the aporencephalic cyst, and also the MRI found white matter pathology around the lateral ventricles here and here. And actually, the last time I spoke with this girl, she was 18 years old. She suffered from a very mild left hemiparesis, and she was diagnosed as having what's called a COL41A mutation. That is a mutation that is known to produce vascular insults in small vessels in the brain, also in the eyes. And when I went back to these old images, you see that also by 23 weeks, the white matter around the lateral ventricle was by this time a little less echogenic than normal, and the pathology was there. Now, this month we publish a series of patients that have a mutation in a gene that is close to A1. It's called COL4A2, and we found that I saw the patients here, and these are the images. This is the first pregnancy I saw. When the patients come to me, they present with bilateral hemorrhage, intraventricular hemorrhage. That even the hemorrhage also affected the brain itself. It was an intraventricular hemorrhage grade 4. And a few years later, they come back at 20. I saw the patient for the first time at 24 weeks, and the ultrasound was completely normal. There was not any finding. And 2 weeks later, it happens again that they have a unilateral, quite big intraventricular hemorrhage. Our pediatric neurologist asked to see the rest of the family, and it turns out that also the grandmother, also the father, and also two sisters of the father and a niece of the father suffer from the same condition and have mild hemiparesis. That they were acting normally, but they suffer from mild hemiparesis. And we performed exomics of the whole family, and we found in this case a deletion of COL4A2. More or less at the same time, we start studying patients that present to the pediatric department or to the ultrasound department with intracranial hemorrhage. And we put together a series of 26 patients. There were 25 families, because one is the family that I told you. And they were, from the 26, there were 9 that were prenatal and 17 that were diagnosed postnatally. All of them have intraventricular hemorrhage, or subpial or subdural or parenchymal hemorrhage. And we found that in these families, four subjects, 3 in the 5 families, that is 12% have a mutation in the genes that we are speaking about, that is called COL4A1, COL4A2, and TREX1. And we found another 5 cases that have potentially mutation that can produce the intraventricular hemorrhage. And this paper has been published a few months ago in Annals of Neurology. So in conclusion, not all the cases of intraventricular hemorrhage or intracranial hemorrhage are due to an insult. Some of them are genetic, and whenever you see an intraventricular hemorrhage, you need to study the whole family, and if possible to do exome to try to understand if there is something that is de novo, will not happen again, or is transmitted from the father or the mother. Okay. Again, we have questions or comments.
We don't have questions. In one of your cases, the intracranial hemorrhage is recurrent. Did I understand correctly?
There are two patients. This is the first pregnancy, the pregnancy that is 3-4, this one.
Yes.
And this is this pregnancy, the 5th pregnancy.
Yes. Okay.
Okay, but since it's happened in the first one, I decided to follow the patient every 2 weeks. Mm-hmm. I performed my self-examination, and this was completely normal. and 2 weeks later, boom.
Yes, I understand. Okay. Are there any questions? There isn't any question. Wait a minute, please.
Okay, continue.
There is another question, but is not completely related to that case, but an important one. Do we need to offer coronal screening in all patients mid-trimester scan for brain?
No.
No. Okay. Mm-hmm.
It depends on what you will to obtain. It's almost the same question. Do we need to offer all the patients to perform a third trimester examination? It depends on the rich, on the economic situation. It depends on so many things that it's very difficult to say what to do. And I today, everyone looks a little bit more than this is required. And as an example, today we performed during the second trimester, we performed the second trimester examination later, at 23, 24 weeks. And at this time, we performed to all our patients, we measure the cervix. To measure the cervix, we perform transvaginal. So if the fetus is in vertex presentation, also I look a little bit to the brain. But it's not part of what is required by our societies.
Professor Manninger, case 2 presents as an intracranial interventricular hemorrhage. How do you manage or counsel the patient or family in the case of interventricular hemorrhage grade 3 or grade 4?
I am. There is a difference between what you think should be done and how you counsel the families. Because I think that you have the same situation in Turkey. The families that come to us come from different places. In our case, they have different religions. They have different beliefs. So if I see a secular Tel Aviv family, most of them, when there is an intraventricular hemorrhage grade 3 or 4, they will go for termination.
Grade 1, 2, or 3, 4? Which one?
3, 4. 3, 4.
3, 4, okay.
If it's one or two, again, we are very conservative. But it's 3 or 4, the prognosis is generally bad. And when you tell the patient that the chance that your child will have a cerebral palsy or epilepsy or will need for life a shunt, most of our secular families will go for termination. On the other side, if the families are Orthodox Jew or there are Muslims that believe, and we know how to recognize. It will be harder for them to decide. They will need to consult with the religious authorities. There is a movement, there is a change. I am going to show you that in some cases, even very Orthodox Jews and Muslims will receive authorization for termination. But if I know that they will never do that, I need to write. I propose the possibility, but I know that they will continue.
Okay.
So I refer them for neurosurgical consultation. We try to explain what to happen, but usually they continue and they deliver.
So in grade 1 and 2, you behave as a treat patient as a conservative way.
Yes.
Grade 3 and 4, you constipation, termination.
Yes.
Okay. Thank you very much.
Gustavo, another question. Dr. Jem Sanhal asks, how can I differentiate periventricular normal echogeneity between periventricular CMV-related echogeneity? It's a difficult question, but please.
It's a good one. Again, in 2 weeks, there will be a webinar from ISWOC lead by Asma Halil on infections, and I am going to show the differentiation. But first of all, you should never do that by transabdominal. If you want to look at the periventricular tissue and see there's a difference, go transvaginal. Or use a high-resolution probe by transabdominal, because it's very, very, very difficult to use transabdominal to differentiate. You will have a lot of false positives. Second, rarely you will have a case that is only periventricular pericogenicity. Usually, these fetuses have also mild ventriculomegaly, cyst, calcification, something else. And again, it's an issue of experience. It's not easy, but when you know how you know what to look for, it becomes with time easier and easier. But usually you will have something else. Let me continue.
Okay, please.
Case 3. This is an easy case. Okay, the patient is 19 weeks and 2 days. It's quite rare that we see patients so early in pregnancy, because we see them at 14, 15, and after that at 22, 23. But it was very clear they have a severe spinal malformation with hemivertebra, with scoliosis. And note here that these two ribs, they go to the same vertebra. The wall spine is very bad. I don't need to tell you that, because it's clear for every one of us. Okay, again, here you have the images of the spine. But we start looking at the brain. And from the beginning, it was clear that also the brain is abnormal. And look here that the interhemispheric fissure is continuous. The lateral ventricle for 19 weeks are a little bit different one from the other. Nothing wrong. But look here in this image, you see that the shape of the lateral ventricle is abnormal. Also here, you see that the midline is not correct. And when we tried to see the corpus callosum, it was very difficult to see it. The lateral ventricles are not dilated, it's 8 point. And again, you see the difference in the shape of the lateral ventricles. And we make an effort to try to see the corpus callosum. In the coronal planes, again, you see the interhemispheric fissure is continuous. You see here the tela choroidea. There is an asymmetry of the shape of the tela choroidea. The third ventricle is here. And using without color, if you are exactly in the midline, and with color, you see that something here is very wrong. Again, the choroid plexus is here, the tela choroidea, the choroid plexus, the third ventricle is here. And you see that anterior to the corpus callosum should be here. And you see that there is something, but actually you understand clearly at this time that the corpus callosum is wrong. And to be sure that we are exactly in the midline, we use 3D. And you see that here there is a small structure that is probably the corpus callosum, but it's a corpus callosum that is abnormally shaped, abnormally developed. And the moment that you see this with the severe spine defect, it's clear that you are in the presence of something that is very wrong. It's a kind of syndrome, and the prognosis in this case should be bad. I move to case 4. Okay, in case 4, okay, this 23 weeks and 3 days, the measurements are normal of the head circumference and the BPD, but there is something that is wrong, and it's wrong from the transabdominal axial cut. Look here, you see that the brain, instead of reaching the midline, the brain stops here. And also here, the brain stops here. There is a lot of fluid or a lot of substance in between. And when you look at these cuts that are parasagittal ones, you see there's a lot of fluid around the brain. Don't look here, but here you will see a lot of fluid in every case. But you see that the amount of fluid is quite big also here. And something that you can make the diagnosis by transabdominal. You don't need to go to transvaginal. You don't need coronals. Look at this image, 23 weeks and 3 days. You see the suture. You see here the Syrian fissure. Okay, and you need only to put this a normal fetus that you know for sure, the one that come before this one or after this one. And this is at 23 weeks and 5 days, and this is at 22 and 4 days. And you see how should look the Syrian fissure in the transabdominal, simple plane at 22, 23 weeks. And you see that here something is wrong. And what is wrong is a arrest of development or a late development of the Syrian fissure that is always associated with a very bad prognosis. And when you go to the transvaginal and you look at the corpus callosum, you see that the corpus callosum here is very, very thick. It's there, but it's very, very thick and eventually abnormal. Now, why I am showing you this case? Because always you can go a little bit, look a little bit more. And look at this coronal plane. Look at this structure here. Okay, here is the third ventricle. This is the cotella choroidea. This is the Monro. This is the Monro. The choroid plexus in the lateral ventricles. But you see this structure have an H shape. What is this? Sometimes you don't know. And until now I don't know. I think that is an overgrowth of the septum pellucidum or of the fornixes. But I have never seen a similar case. And if you can help, it will be nice from your side. And we perform also an MRI of the same patient, and the MRI show correctly that there is a abnormal development of the sulcation. It's a case of early dysencephaly. And when you look at the corpus callosum also by MRI, something here appears very wrong.
Are there any questions?
There was a question about measurement of corpus callosum. Sometimes we can see that the right and left wing of corpus callosum can appear different. If you measure on the right or on the left side slightly, not on exactly mid-sagittal section, can you measure different sizes? Is it important or to have...
This is, I need to know, this is your question or from someone else?
Actually, this is my question, but someone else also, Cengiz also asked the question. You know him.
Okay, so you are good. It means that you are good because we are now dealing with this issue. We realize that a lot of times the corpus callosum, you know, one side is larger than the other. And when you look in the coronal plane, they are asymmetric. I have no absolutely idea what is the significance of that. I don't know. We are aware of that. We have our case. We're collecting them. But I want to, you know, to predict that this is nothing. Again, if this isolated, the fetus is completely normal, and you see that, most surely will be nothing. But it's a fantastic question. Put your cases together and we can publish them later on. I don't know.
There is another question about termination of the pregnancy. Is it possible to terminate the pregnancy in late gestations in Israel? Do you?
Yes, sure.
That's, okay.
The law of abortion in Israel was established in 1973, and by this time there was no one was thinking in the possibility to make late terminations, to make feticides, because there was not ultrasound, so they didn't put a seal. Okay, there is not a roof, so we can perform. It's like in France or in England, we can perform termination even at 40 weeks. but we need the authorization by a very special commission that is formed by the director of the hospital. It's not easy.
The last question, again, I didn't want to forget it. Is ganglionic eminence cyst have better prognosis in late pregnancy? Did you say that, or
yes,
I misunderstand?
yes. Look, if you have possibility to read the White Journal, we published. No, it was in prenatal diagnosis. We published last year a paper with cases of CMV that we knew that the fetus has CMV because all of them have positive amniocentesis, and the only finding we saw was a very echogenic ganglionic eminence late in pregnancy. The ultrasounds were normal, and late in pregnancy, in the remnants of the ganglionic eminence, you see them white, echogenic. And we follow these children, and they are doing exceptionally well. And again, we have the case of the periventricular pseudocyst that is in the same place, and again, the prognosis is good.
I have a question, Mallinger. What's your last position about isolated thick corpus callosum?
Isolated agenesis?
No, isolated thick corpus callosum.
Isolated thick?
And there isn't any other finding. The shape is normal, only thick, that's all.
This is exceptionally rare.
Mm-hmm.
Okay, also in the literature and also in our experience. But we have, the issue is that many times you say, we publish on that, many times you think that the corpus callosum is thick, but actually there is something else. It can be a lipoma, the prognosis is good. Mm-hmm. Sometimes what you are seeing, you think that this is a corpus callosum, but actually there are two cingulates. There is a supracingulate lobule that is normal, and you think that is a thick corpus callosum because you are used to see only one. I have a lecture on that, and we publish on that. It's in the White Journal. If there is isolated, I think that and you find an explanation, the prognosis is good. If the fetus has macrocephaly plus macrocephaly, but with a very big and thick corpus callosum, it can be syndromatic.
Thank you. Please go on.
Sorry, Professor Mallinger, I have a question. Actually, this question is asked by Professor Acar. Last week, he had a case. He's asking that the grade 3 or 4 intracranial intravascular hemorrhage, even if it's happened or present in 33 weeks, do you prefer the termination or give a choice for termination?
You need to ask the question again. I didn't understand the complete.
So, the intracranial hemorrhage.
Yes.
Grade 3 or 4.
Yes.
Even if it's present in the 33 weeks.
Yes.
How do you manage it? Do you give the termination choice?
We recommend to consider termination.
Okay. Thank you.
Thank you.
Okay, next case. Okay, this is a case a few months ago. The patient is 25 years old. She's gravida 1. Normal pregnancy until 21 weeks. When the myometry becomes smaller than expected, ultrasound examination at 24 weeks, there was an echogenic mass of 7 millimeters in the left ventricle of the heart. Fetal echocardiography at 27 weeks, same finding, consistent with a single rhabdomyoma. Repeated ultrasound examination was a normal brain, single cardiac finding, IUGR. MRI at 32 weeks, suspect tumors in the brain. And we performed an ultrasound at 34 weeks, and we saw what I am going to show you now. First of all, when we see the patient at 34 weeks and 6 days. Okay, there was IUGR. It was 1.2% according to Hadlock, with a very small head circumference, very small abdominal circumference, very small femur. And the weight estimation at 35 weeks was 1 kilo 800. And this is the examination of the heart. And everyone can notice that there is not one rhabdomyoma, but there are multiple rhabdomyomas, many of them in the septum, left ventricle, but also in the right atrium that are quite rare. You will see here that there is a one, you see? In the right atrium, you see one. The moment we saw that, it's clear that the fetus has tuberous sclerosis. So the next step when we see that is to go not to the brain, but to go to the kidneys. And you see here in the left kidney, this is the left kidney, it was apparently normal. In the right kidney, there was again a tuber that you can see it here. And from here, we go to the brain. And look at this brain. Probably you will say, there is nothing, but I am going to show you with arrows and you're going to see what happened. Look this one, look this one, look this one, look this one, look this. Okay, again, this is a fetus that have multiple rhabdomyomas in the white matter, in close to the gray matter of the brain. The prognosis in this case is very, very, very, very bad. We recommend for termination, but again, this is a religious family, and they were delivered 1 week after that at 35 weeks. And as expected, the findings are asked in the ultrasound before delivery. We see from time to time 2 cases of tuberous sclerosis, and everyone that say that you cannot see the tubers in ultrasound, this is to show how wrong you are. The differential diagnosis in case like that, usually with lateral, if you have also ventriculomegaly, can be toxoplasmosis. They are very similar, but toxoplasmosis don't have rhabdomyomas in the heart. Questions?
Okay, there is no question about this topic. Please go on.
Okay. I move. Case 6. Again, cases from the last month. I saw this patient where the blue arrow is at 35 weeks and a half, and the head circumference was well larger than 3 standard deviation. All the examinations were performed by one of the best ultrasonographists in Israel and were considered normal, but for the rise in the head circumference. And this is the ultrasound and the MRI. A very large head with a lot of fluid around. The MRI was considered normal, but for the amount of fluid around. But I didn't like the growth of the head circumference so fast, and I recommend to perform exomics. And exomics was performed almost at 38 weeks, and it arrives very fast. In 10 days, we have the answer of the exomics, and the answer of the exomics was of the de novo previous and report missense heterozygous mutation in the gene that is called CDH3, and this is the place where the mutation occurred. And the mutation by itself, since it was not previously reported, was considered of uncertain significance. But the moment that we went to the literature, we realized that the mutations in these genes are associated with something that today is called Schnitzler's Bloch-Kampau syndrome. There are only these 2 papers in the world literature. The first one was published in Nature in 2018, and they were 35 children that were diagnosed with this condition. They found 1 child in a group of children that have speech disorders, And they found this mutation, and so they went to a larger population of children with peak mutation. And in this large population, they found 35 children that have a variant, a mutation in this gene. And you can see here that 58% of these children have macrocephaly, and 33% have a widened cerebrospinal fluid in the MRs. So the moment that we saw this, and there was this other article again, that they have a prominent extra-axial space when you put these 27 cases overall was very common, and also macrocephaly was in more than 50% of the cases. It turns for us from a case of exome of uncertain significance to one that is likely pathogenic, and the family opted for termination. And what you see here is the child after delivery. More or less at the same time, we have this case. It was again two or three months ago, and this is a fetus that come to us with a head that the head circumference was 2.7 standard deviation. We used Chevernak tables at 31 weeks. It was a big head circumference. The corpus callosum, again, was thin, but very, very large. We tried to obtain images of the face, and this is the image of the face we were able to obtain. And also this one, where you see that the corpus callosum is here. This is a little bit irregular, but should I see only that, I will never make a diagnosis that something is abnormal here. And look at the face. The lips were quite prominent. We perform an MRI, and the MRI was completely normal. And again, we send for Wes, and this time we receive that that is a pathogenic variant in the gene that is called PIK3CA, that is causes overgrowth syndromes, and this is a fetus that's what's called macrocephaly capillary malformation syndrome. This is the fetus after termination, where you see the huge big head, and again you see that perhaps in the lips there is a capillary malformation. We are not completely sure. We are waiting for the result of the postmortem examination because it happens 2 months ago. And actually, you know, long time ago, when we sent our first cases of macrocephaly, Stuart Campbell told me, "How did you find 4 cases of macrocephaly? In my whole career, I have never seen one." And the issue is that you find these cases if you continue following the patients quite late in pregnancy, because as with microcephaly, most of these cases will not be apparent by 24 weeks or by 23 weeks. Questions?
What's the limit of microcephaly in the 3rd trimester of pregnancy?
Micro?
Micro.
Yes.
Macro. What's the limit? 3 standard deviation, 2 standard deviation.
No. We did a study of 100 fetuses, and when the head circumference is, you have macrocephaly more than 2.5 early in pregnancy, or when is more than 2.6 late in pregnancy, you should suspect that something is wrong. It's like with microcephaly. Not all the cases will be abnormal, but if you see a fetus that is rapid, the head circumference rapidly growing, you are in trouble, and you should perform today exomics. Perhaps it's the first tier. You should do perhaps the exomic even before CMA, because the chances that you will find something by exomics is bigger by 2 or 3 or 4 times more than if we perform a CMA.
Thank you very much.
Excuse me, sir. In this point, how do you define microcephaly? Micro, small head circumference.
Yes.
-2, 3 standard deviation or 5, 3 to percentile? Which one?
It should be less below -3 standard deviation, isolated. Below 3 standard deviation,
That's good.
we start worrying. Between 2 and 3, -2 and -3, we have found that most of these cases there are girls, because girls have smaller heads, and most of the cases, if they are isolated, they do well. So we start being worrying when we find the head circumference below -3.
3. Okay.
And it's very important. It's very important to measure also in micro and also in macro. It's very important to measure the head circumference of the parents, because the father, usually the father will have a very big head, as I have. As the fetus has a big head, you are a little bit more reassured. And also, if you have a family that have all of them have small heads, it's to be expected that this child will have small head, and most probably normal.
Okay.
Okay. Look at this. This is an interesting case. No, because what we see, because diagnosis was easy. The patient come to us at 36 weeks to plan delivery because of the presence of an intracranial mass that was diagnosed during second trimester ultrasound examination, and the patients didn't consider termination of pregnancy. They have consultation in 4 hospitals, very important hospitals, no, three important hospitals in Israel, including our pediatric neurosurgery department that is the best in the country. And they come to us for cesarean delivery. Because they were willing to continue pregnancy, there was a family of Bedouin origin in south of Israel. And when we start the measurement, we were astonished because at 36 weeks, the head circumference was 40 centimeters. That is something unheard. And we have the MRI. And here you have the MRI, that there's a huge, something is apparently a huge cystic lesion in the brain. But when we did the ultrasound, we found that there is a tumor. Okay, also the MR knew that it's a tumor, but they were not completely sure what kind of tumor is. You see the very, very, very big head with frontal bossing, the frontal bossing in the fetus. And what we did here, one of our physicians called the Qadi, called the religious person where these people live, and he personally explained to him that here the prognosis is very bad. Not only is very bad, but it can damage the mother because she will need to go to cesarean section, and you never know what happened there. The head is so big. And because we were able to communicate with the person that was able to decide, the family opted for termination of pregnancy. During the termination, we perform an autopsy, biopsy of the tumor, and this is the diagnosis is high-grade neuroepithelial tumor that is very, very rare because it's BCOR negative and also PCR 53 negative. This is the histology. Okay, it's a sharply demarcated, highly cellular tumor composed of uniform spindle cells, 2 ovoid tumor cells with scant fibrillary cytoplasma. Very bad tumor, inoperable, and with a very bad prognosis. It was negative for the mutation in the BCL6 compressor BCR gene. It's negative, that is even more rare. So this is a simple case, but I was only trying to show you that sometimes the case is not important, but the patient. And case 9, I try to finish with something that is a little bit more with a better prognosis. And this is the granddaughter. The fetus is the granddaughter of my physician, my personal physician. And she come to me for a ultrasound, and this is what I saw at 16 weeks. The measurements, everything was completely normal. I was very happy. But the moment that start going out, taking the transducer out from the vagina, this is transabdominal, but taking the transducer out from the vagina, I saw this cystic finding here. And the moment that you see something like this, you ask, it is possible to have better images? What is the diagnosis, differential diagnosis? Is possible to diagnose this find before? Will an early diagnosis modify the management? These were my questions, and I am going to answer to them. You see, yes, you can obtain much better images by transvaginal, as in this case. And what you see here is the mass. You see that the skull is not affected, and you see that there are no vessels. There are not falcine vessels irrigating the tumor. You see here that there is a membrane around the cysts. And here are the images. And now the differential diagnosis is quite wide, but if you know the condition, you don't need to make a differential diagnosis. You are almost sure of the diagnosis, that is the dermoid cyst. And if you go to the literature, there are many cases in the literature showing dermoid cyst. You see this one is by one of my, by Divya Singh, that she was here in the master class 2 years ago. And this is from my friend Waldo Sepúlveda and Edgardo Corral, showing the cyst. And now the next question, is it possible to diagnose this finding before? Yes. Look here, it was difficult, but when you look to transvaginal, it was present at 14 weeks. You can see it here. And actually I saw it at 14 weeks, but for the interest of the pregnancy, I changed a little bit the history. And if you look at during the nuchal translucency at 11 weeks and 6 days, it's not there. It's not there. It's difficult to see if it is there or not. But at some moment in the 3D, you have here something that is very difficult to be sure that is this. You look here. Perhaps it was there at 11 weeks. Not completely sure. And the question is, will the early diagnosis modify the management? And most probably not. And here you have the baby that was born a few months ago. And you see that even it's difficult to see where the dermoid cyst is completely normal. I rest my case, and thank you for your patience and for being here with me. And sorry for disturbing you from your Friday, but you are at home.
Thank you very much, Gustavo. There's some questions. One of them is from Professor Namık Demir. He's the boss of our society for today. He asks about porencephalic cysts. If the fetus has unilateral porencephaly, diameters 45 plus 45, 34 millimeter, and the other hemisphere of the brain was completely normal, and there was no other fetal malformation, knowing that it has an excellent neuroplasticity capacity in brain tissue, how should we manage this case at 35
okay,
termination or neurosurgery?
This cyst of 4 centimeters, how many weeks was the fetus?
45, 33, yes, 34 millimeter diameters.
At which gestational age?
35 weeks.
Okay.
35 weeks.
And I need to know the position. Where was it? It was in which place of the brain? It depends. It's very important to know where it is, because if there is isolated and everything is normal, this child will have probably some kind of hemiparesis, but it depends where it is. So you will be able, the pediatric neurologist will be able to determine what will be the prognosis. Is in the right side or in the left side? Is in the motor zone or is in the sensory zones? It's close to the lateral ventricle or it's far away from the lateral ventricle. So you can give a prognosis. I show one case where the porencephalic cyst was quite small. Is the case of the call called for A1. A1. This patient, you need to have a very good anamnesis of the family to see if there are not any other person with visual problems or with hemiparesis. We have a family that have also one child with an omphalocele that was treated because, again, there are problems of the medium-sized arteries. So if you have a good anamnesis and it's placed, let's say, frontal, the prognosis can be quite good. If it's placed in the parietal zone of the left side, most probably the child will have right hemiparesis. It depends. Mm-hmm. If you want to send me an image, I will try to help a little bit more.
There isn't any image now here. Maybe Professor Namık Demir will send you some message, some pictures after the lecture. Another last question, Professor Selim from Büyükkurt. He asks about hypoplastic left ventricle aortic atresia. In such kind of cases, what do you think about end result in CNS malformations of these specific cardiac malformations?
Okay, my experience with these cases is not very big because usually 99% of the cases with a left hypoplastic heart syndrome in Israel will went to termination. The results of surgery here in Israel for these cases is not very good. The experience is not very good, so most of the cases will go for termination. But according to the literature, they are more prone to have brain malformations or brain insult damage. Is something that is quite similar to what happened with a fetus that is anemic. So if the perfusion to the brain is abnormal, the chances that something will be wrong are quite high. I am almost sure that there is not a malformation of the brain that you will find, but you will find insult, less perfusion, less oxygen, and abnormal brain.
And a last question, you are very tired, from Professor Acar Koç. Do you have any knowledge about the hemorrhage-related right frontal ischemia, prognosis of hemorrhage-related right frontal ischemia? The question is that one.
Unilateral?
That's all.
Right
frontal ischemia, hemorrhage-related right frontal ischemia.
Again, it depends on the size, but we know that it's usually due to a perinatal stroke that can occur from 20 weeks to 28 days after delivery. Okay, mm-hmm. These children usually present with two different clinical presentations, or they start to have convulsions, epilepsy fits during the first 2 or 3 days, or they have later on asymmetric movements, or again epilepsy later on in pregnancy, and sometimes it depends of luck, how lucky you are. Sometimes they do extremely well in comparison with the extension of the damage. I have now one family that she's pregnant and they have a child at home that they had a stroke involving a huge portion of the mid-cerebral artery, the second and third portion of the mid-cerebral artery. They have a huge porencephalic cyst, and the child is doing extremely well.
Thank you very much. Professor Recep Has and Ahmet Gül, do you have any contributions or questions to Mallinger?
Yes, I have. Professor Mallinger, you said there is no isolated thick corpus callosum. Maybe very rare. Is there any isolated thin corpus callosum? Thin. Do you use it?
Yes.
This terminology?
You know, we are in these cases we are playing with fire, because it's like throwing a coin. You will see cases, and in my lectures I usually present two cases with the children that have extremely thin and abnormal corpus callosum. One is doing perfectly well, and the other one is severe microcephaly and very abnormal. So to give a prognosis based on anatomy, I always tell the families, you know, what we see is the anatomy. We don't see function. And by now, we are not able to say what will happen with your child. And eventually, a lot of times, based on experience, I work with my heart instead of my brain. But there is not a clever answer that I can give you.
So you don't expect isolated thin or thick corpus callosum exclusion. It's very rare, you mean?
You need to see these cases one by one, and again, you know, it's very difficult because you receive the patient is referred to you because I said the corpus callosum is thin. You perform an MRI, and the guy of the MRI says the corpus callosum is very abnormal because it's thin, but you see nothing else. So what the chances that something is wrong? It depends. I have recently saw a paper from France where they performed DTI, tractography, and there is also the group from Professor Pryor and Kasparian from Vienna that they are trying to make a prognosis based on little findings that they see in the MRI. They are quite optimistic. The paper that they review from France was very clear. You don't need DTI. If you see the corpus callosum is abnormal, it's bad. If the corpus callosum is thin, but the shape is completely normal, it's good.
Okay, thank you.
Recep var mı?
Professor, if you have time, there were two more questions. One is about MRI, use of MRI in brain abnormalities. What is your approach? When do you use, in which cases, and in which gestational age? The first one is this.
There are three. I will answer very fast. There are three indications. First of all, I am not sure what I am seeing. I have a question to the MRI. I want to ask the MRI something because I am not sure. Second possibility, I am completely sure that what I am seeing, but the patients need reassurance to reach a decision. Two. And third medical legal point. If you don't perform an MRI, if something went wrong, they will say, why you didn't perform? Usually will not help. But again, it depends of who is the person that performed the MRI and who is the person that performed the ultrasound.
Okay.
The second question.
The last question is about intracranial hemorrhage again. What is your workup when you see hemorrhage? What do you look for? Thrombocytopenia, or how do you look for? And how do you manage if the pregnancy continues? Do you offer C-section, or do you let vaginal delivery?
Yes, usually if there is an hemorrhage and the patient decides to continue pregnancy, they will go through cesarean section. This is the easy part of the question. What to look for? Today, I think that you need to exclude thrombophilias. You need to exclude alloimmune thrombocytopenia by studying the parents and the fetus, or doing a chordocentesis to look for thrombocytes. And today, the first exam should be exomics.
Another interesting question: is there any intrauterine epileptic seizure did you observe?
If there is
epileptic seizure, epilepsy of the fetus.
It's extremely rare. Perhaps I have one or two cases that the fetus did something like that. You are never sure. I have seen a case by Daniela Pryor where she saw a fetus with severe microcephaly, almost anencephaly, that have a fit. But in a normal fetus, to see a fit, in most of the cases should be that you disturb the fetus and he was willing to fight against you, not a true fit. But it's very, very, very, very rare.
Okay, it's not fighting. Huh? Başka soru yok. Thank you very much, Gustavo.
I hope I will be in a few weeks or months there, and I will come to say hello. No lectures.
So you are welcome. Good food.
The good food, yes, I know. My son was very, very, very, very, very, very willing to go, and we are very disappointed. But I hope it will be for good.
Yes, the Dr. Handan is very good person about this procedures. Okay, we will wait you and your son. Okay, thank you very much.
Thank you very much.
See you soon personally.
Okay.
Thank you.
Bye.
Have a
Bye
good
bye.
night.
Thank you.
Bye.
Bye.